Hi everybody. This is my case presentation for this week on Adeline, who is a 42-year-old G2 para 2. Here is her date of birth, 4/15/1981. She was seen on the 25th of October. Adeline's chief complaint is heavy, painful menstrual periods. She's a 42-year-old who is endorsing painful, heavy menstrual periods as well as intermenstrual bleeding within the past 3 months. She has no known drug allergies. This is her past medical history, which includes chickenpox in 1986, measles, depression, and gestational diabetes from her second pregnancy in 2007. This is her family history. You can definitely see that she has diabetes within her family history and hypertension on her mom's side of the family. As well as colon cancer from her father, and her mother has a history of dyslipidemia and thyroid nodules. Definitely something to be of note in this particular case. She has no surgical history. Social history, she endorses that she does not smoke cigarettes. She does drink alcohol socially on the weekends, but does not partake in illicit drug use. She specifies 3 beers in total over the weekends. She does live with her spouse of 4 years, and she works at a local TJ Maxx as a store manager. She does have 2 children who are 16 and 18, and she is divorced from the bio dad of her children. She does feel safe at home, and she does not have any kind of suicidal ideation. Her gynecological history includes the last menstrual period of September the 24th. She has an obstetric history listed below, G2 para 2 live births, one of which was a premature delivery and had complications with gestational diabetes. She got her first menstrual period when she was 10 years old, and she typically gets it every 25 days and bleeds for 4 to 5 days. She has one sexual partner, it is her husband of 4 years, and he has had a vasectomy. Her current medications only include fluoxetine, 10 milligrams Q-day PO for her depression. Her ROS is generally benign. She does appear a little bit obese, but she is in no acute distress and is engaged appropriately in conversation. She has endorsing no issues with her eyes. She's not having any chest pain, palpitations, or a racing heart. Respiratory-wise, no shortness of breath, wheezing, coughing. Gastrointestinal, she has regular, consistent bowel movements, does not endorse any nausea or vomiting. GU, no dysuria, flank pain, increased frequency, or hematuria. Musculoskeletal, there's no issues, and she's able to complete all of her ADLs, and she has no psychiatric issues at this time. She does have her depression well under control. I would ask Adeline a couple key questions to kind of suss out what's exactly going on. I really would like to know, I should have specified husband, if he's had any other sexual partners, just because STI is immediately on my mind for the increasing bleeding. So I want to just make sure that there's no chance that she could have a sexually transmitted disease. I also would like to know if she has a family history of uterine or ovarian cancer from any other close first-degree relative, because this could increase her chances of uterine and ovarian cancer, as well as endometriosis, if she is knowledgeable of any first-degree relatives that suffer from endometriosis. I also really want to know, how much is she bleeding? Is she soaking a pad an hour? If so, that's extremely concerning, and that would also raise a lot of flags about her hemoglobin and her hematocrit and how much blood she's actually losing. As well as the bruising or anything of note around that. So that, and of course, would help kind of dictate the plan of care, not necessarily the diagnosis, but if she was having low H&H, we'd want to definitely address that right away, or low iron. Is this the first time she's experienced dysmenorrhea? And is there anything that she does to help with it? Hot packs, NSAIDs. Can she tell me on a scale of 1 to 10 how bad the pain is? Has it kept her from going to work? And is this one of the patient's last pap smear? Has she had any history of abnormal pap smears? Cervical cancer is definitely the first kind of thing on the forefront of my mind, so I really want to keep an eye on that and kind of see if she's had anything abnormal in her past, and has she had any dysmenorrhea prior to the last 3 months, because what we do know is that girls who have dysmenorrhea early in life and experience it later as well and continuous, they could have an increased chance of endometriosis. This is all of her objective information, all of which is extremely benign. We don't have to go through all of it individually, but it's nothing of note on this exam other than that she is a little bit overweight, but I'm not seeing anything of obvious issue on her physical exam. I would like to highlight that I don't see any polyps present at her cervix. Of course, a speculum of exam can only show us so much. We can't see inside of her uterus, which could have polyps present, and that could also be a cause of bleeding. So we'll get onto that in a moment, but everything else, as I stated, is benign, extremities, musculoskeletal, neurologically. The labs I would order for this patient would be a pregnancy test right away. We need to rule out that she's not pregnant. That would be definitely a sign of bleeding. I want a complete blood count. I really want to know what her H&H is. As I talked about earlier, I just feel as though we just want to make sure she's not in need of, if she's anemic and in need of blood. We also want to know her thyroid level, because this can cause abnormalities in her bleeding. Hyperthyroidism and hypothyroidism, as we've learned, can increase and decrease bleeding in a woman, so we need to just kind of understand what's going on there, as well as STIs. Gonorrhea and chlamydia can increase a patient's chance of bleeding, and a vaginal culture. So we can do all those in one swab, and that can also give us if she has bacterial vaginosis and or pelvic inflammatory disease, which can increase a woman's menstrual bleeding and intermenstrual bleeding. And as well as a pap smear, because we want to assess for cervical cancer. We come to the diagnosis that she has menorrhagia, dysfunctional uterine bleeding. The plan, it starts with diagnostics, and that includes like the previous tests we talked about: pregnancy, CBC, TSH, STI testing, vaginal culture. We're going to get in-depth medical history, her family history, gynecological history, physical exam, pelvic exam, where else we'll be able to see if she's had any visible polyps that can cause bleeding. That'll be obvious on a pelvic exam with a speculum. And then the rest of these are all possibilities. As we said, this could go in so many different directions depending on these initial findings. So I just listed them here because this case could get really in depth depending on what we see from the initial diagnostics. And then we go on to the pharmacological interventions. I am more inclined to give her the progesterone-only pill, not so much an intrauterine device at this time, because she could have an STI and or pelvic inflammatory disease, which wouldn't be a good indication to put in an intrauterine device. So I would probably most likely put on the progesterone-only pill. I would say NSAIDs are best bet for pain management. And then I did leave the chemotherapy and radiation there at the very bottom, because we really don't know, based off of how this is all going to pan out, that she might need that if she ends up with cervical or uterine cancer. And then here's some non-pharmacal interventions listed here: heating pads for dysmenorrhea, rest, and a possible DNC of the endometrial lining of pelvic. Ultrasound shows thickening greater than 4 millimeters. Education, I would just encourage her to eat healthy. I would have her watch her weight, and moderate exercise indicated in overweight women. This can extremely help with dysmenorrhea. She needs a referral for an OBGYN. She needs a referral for an endocrinologist if her TSH is elevated or decreased significantly, and an oncologist if we see positive results in her pap smear for high-risk cervical cancer and confirmed by a cystoscopy. I need the patient to follow up after she's had the pelvic ultrasound so we can discuss plan of care. If I get the results on her STI, vaginal culture, and or pap smear prior to this pelvic ultrasound, I will touch base with her. But we need more information. So we need the ultrasound and we need these test results in order to prescribe any thing necessary based off of these findings. Thank you so much.